Thank you, and welcome everybody. I am going to speed through this and give hopefully some time back to the other presenters. Again, Elliot, Sloane. I have a number of roles in this field. 15 years originally with ECRI in the Philadelphia area, 10 years with a medical device and pharmaceuticals manufacturer, and then the past 20 plus years as a professor and running nonprofit organizations. Remind us that we stand on the shoulder of giants. Dr. Casares passed away in 2020. He held the title professor of clinical engineering in 1960 at George Washington, and in fact was really viewed as the father of clinical engineering and coined the term of clinical engineering. So there are just two of his early articles on the use of computers by physicians for diagnostic purposes and analyzing heart disease. The point I'm making, and will repeat, is that clinical engineers have had a leadership role in both technology and information management for clinical care well, this goes back 60 years. In 2021, I wrote an article in the AAMI Biomedical Instrumentation and Technology I titled The Golden Age of Clinical Engineering, Digital Convergence and IT Partnerships. Oh, that's the topic of today's discussion. And in fact, we had seminars at both AAMI and at HIMSS joining clinical engineering leaders and CIOs in hospitals talking about how their evolving collaboration was proceeding. Now, as this was unfolding, we were also at Villanova University, colleagues looking at the profusion and pervasion of wireless medical device networks. We're working with IEEE and other organizations, trying to understand how all of these wireless networks might collide and work together in terms of providing mobile healthcare inside the hospital emporium and outside, at that time, looking a little bit at home care, but also ambulances, EMT, alternate site care, and all of the different interfaces, the various Wi-Fi, Bluetooth, and other interface technologies that were beginning to emerge. And what we found is that the number of alarms from monitors, pulse oximeters, ventilators, anesthesia machines, EHR, EMR, could rapidly overwhelm a Wi-Fi network because of the collision sense infrastructure. 2005 also, in 2006, we were creating a community for interoperability of medical devices with electronic information systems of all sorts, IHE International, in which I became the chair and co-chair for a decade and a half, created a medical devices, we call it personal devices or personal care devices, trying to straddle the consumer and the medical care activities, the connectivity between the devices and also the connectivity with the EMR, EHR that was emerging. The free open source standards are available and published at the website I've noted below. To Err is Human in 1999 pointed out that as many as 98 to 100,000 Americans died of medical errors each year. And in 2005, the Institute of Medicine and the National Academies of Engineering released a joint report about systems engineering thinking, the deployment of computer systems analysis, simulation, modeling, and using the tools that had built robust military and other manufacturing systems to bring to the fore better systems for healthcare. And we began to have a number of webinars and sessions and showcases talking about the role of clinical engineers as systems and systems of systems engineers. Now, all of us are systems thinkers as engineers, but systems of systems is an entirely more complex area of engineering because of the interdependencies of all of the different systems. And by 2009, we were featuring at the HIMSS and AMI showcases many different technologies: infusion pumps, anesthesia, incubators, patient monitors, mobile patient care information, as well as EMR and EHR systems. And we were beginning to get into alarm and alert integration and fusion. So we truly were beginning to see the emergence of systems of great complexity. Back in 2009, also we looked at the IHE, integrating the healthcare enterprise domains, the core domains. When I look at these, I see devices. Now, I can tell you the radiologists, cardiologists, lab folks, radiation oncology, those folks looked at those as their business activities, their medical care activities. But me, I see devices. And in fact, over the past 22, 23 years since IHE was begun, we are now doing more and more and more device interchange and interoperability. I see there's a question in the chat, and it may be that we will actually have the slides available for you to review after the session. And now the extension of body area and wearable and home networks that was already being discussed in the 2009 period. Really, it's important to understand what time period we're talking about, because we're getting to be worried about the high-tech HIPAA privacy and security. 2009, the American Recovery and Reinvestment Act created a whole lot of serious financial and criminal potential exposures for patient information security and reliability. And that time frame, we were talking about CIA, confidentiality, integrity, and availability. And as I will talk about and began talking about in 2009, in our world of clinical engineering, there is also life-critical human safety. So this is a diagram I started to use that says you could have a system that has perfect confidentiality, integrity, and availability and still harm or kill patients if the information being exchanged and the systems being used did not properly interact and create interdependencies to support safe patient care. Now, also, I want to make a mention that this moment of 2009 was just the beginning of iPhones, iPads, apps, all of the Androids, broadband, wireless, streaming video, wearable personal devices, cloud computing, social networking, ransomware, mHealth, eHealth, pHealth, uHealth. We have so many technologies in the past 13 years that have flooded this technology market, and all of them have been deployed through the pandemic and will be in the future. We had a lot of cross-industry meetings that came out of these dialogues in what we call the aughts. Amy had this conference on smart infusion pumps in 2011. In 2011, we also had with Amy a meeting on clinical alarms and clinical alarms integration, which was a program that was also championed by the Healthcare Technology Foundation. Medical device interoperability began to come to the fore, both with the FDA and also with the FAA, the FCC, the Federal Communications Commission, because we're now moving into an area where wireless technologies were being used. And in fact, we had a separate meeting just to focus on this interchange, this interdependency that was emerging. Again, I want to point out that all of this, almost all of this, really was focused on the hospital enterprise. Very little discussion about nursing homes, long-term care, alternate care sites, and home care. Amy has, in fact, an anthology that covers all of the alarm management solutions that the Amy Foundation worked on. And by the way, all of these reports are available for free, these summit reports from Amy. And if you have difficulty finding them, let me know, and I'll be glad to help you get your own copies. Now, Amy does deserve a lot of credit for organizing and orchestrating these meetings with ACCE, CRI, FCC, FDA, HIMSS, and so many others. And this is ongoing. ACCE, IFMBCD, and the Global Clinical Engineering Alliance are all continuing to expand these global conversations with Amy, HIMSS, WHO, FDA, and others. The future of digital health and clinical engineering and information technology confluence, convergence, interdependency is rapidly emerging now. I'm working with groups that are developing standards for autonomous and semi-autonomous medical devices and medical device systems using the IEEE, IHE, and HL7 FHIR standards to connect. If you look on the bottom right, you see a patient where on the right-hand side, there's a blood management system, which is made up of heterogeneous different vendors, products and systems, and on the left, a closed loop fluid management system, all of which interfaces with an interplay of information, alert, and management. Also, we're now working on process optimization. Healthcare is around the globe. We have seen, because of the pandemic, we've had exposed the lack of physicians, nurses, and enterprise capacity to support the number of patients that are really converging on healthcare. So we now are developing tools and toolboxes using open source simulation modeling tools for clinical engineers. At last year's summit in October, I also presented an entire thesis about the opportunity and need for our field to grow its purview, perspective, and skills to deal with all of the telehealth and telemedicine that's emerging. I didn't have time in that session to talk about all of the AI and machine learning that's emerging. And all of that is part of our clinical engineering responsibility. We are also looking at areas such as digital twins. There's a lot of research that has been done in the military area with using simulations based on real systems and devices and organizations, creating digital twins in order to run experiments without harming the individual. And this is another area. As this emerges, how do you validate such models? How do you ensure that these models represent reality? How do you correct these models if they are wrong? Confluence, an example that was just published in June, is this article, Emerging Artificial Intelligence Empowered mHealth, a scoping review. There is so much convergence and confluence of clinical and information technologies that it is a very exciting time. Just looking at the COVID-19 pandemic, I looked at the National Library of Medicine PubMed, articles just during the pandemic related to COVID or SARS or pandemic. So this is not everything in telehealth and telemedicine. This is just related to the pandemic. Over 10,000 articles on telehealth and telemedicine, over 6,500 articles on machine learning or artificial intelligence, 5,000 articles on EMR and EHR, 20,000 hospitals on home care and virtual hospitals or clinics, and other 600 plus articles on remote patient monitoring, which has really become an extension of the hospital and an extension of some of the telemedicine and telehealth activities. Since February of 2020, I and a group of clinical engineers have been managing a daily newsletter, Hacking COVID. All of the Hacking COVID citations are available for free, as is subscription. You can use the link that I'm showing here. We dutifully go through all the literature that we can find from around the world and cite practitioner-based useful articles or C-suite management of hospitals or ministries of health. And two examples below, a recent article on the Internet of Things for chronic diseases during COVID-19. That's actually engineers in Iran. And this article I showed you before by engineers in the USA about this convergence of artificial intelligence and mHealth. Again, by this link, you can get access to all of the articles, because a bonus out of the pandemic, if there is one, is that all of the publishers agreed to let us use their articles free without paywalls. Well, that's what the past 50 years has looked like in the clinical engineering and digital health area for me. From Casares in 1960, 60 years ago till today, clinical engineering and digital health have always been perfect together. Thank you, Cesar. And let me finish where I started 20 years ago in 2001. The golden age of clinical engineering is now, as today's speakers are about to tell you. Thank you for allowing me to join you, and I look forward to the presentations for the rest of this session.